outside Nigeria. The fan have had several very rich presentations anchored by eminently qualified individuals. Today is going to be another masterpiece of presentation from Japan. The topic for presentation is one of the very unfamiliar topics being presented on this platform. The topic for today's presentation is opioid withdrawal and locus ceroleus neural pathway, the cardiovascular implications. So it is an honor for me to moderate. My name is Dr. Lawal Mohammed Omoya. I work with Federal Teaching Hospital, Locus, Kogi State. And the presenter is our own Dr. Yusuf Alkali Ibrahim, a specialist in neuropharmacology, Department of Pharmacology and Toxicology, Faculty of Pharmaceutical Sciences, with Madam Fuji University, Sokoto.
Locus.
Let me quickly, in absentia, recognize eminent personalities. Recognize our AD chairman, our pragmatic and dynamic erudite chairman, Dr. Joseph Madi, and other eminent personalities in our midst, the fellows of West Africa Postgraduate College, pharmacists, professors in the house, and all the invited guests. You are all welcome to today's presentation. I urge us to pay more attention and jot down points, questions, or contributions as we progress. Opportunities will be given to attend to questions and contributions at the end of the presentation. I also want to plead that we all use our mic, except myself, the presenter, that should have our mic on. This is to avoid sound interference from the background so that we can get the gist of this presentation. As I said earlier, if you have any comments or questions, just please jot it down, and you can go to the chat box and signify here that you have questions or comments by just raising up your hand here. You will be attended to at the end of the presentation. So at this point, I want to call on our presenter to take charge as we listen to the presentation. So Dr. Yusuf Alkali,
yes, sir. Yes, sir. Thank you. Yes. Am I audible, sir? Can you hear me?
Yes, you are audible.
Okay, thank you very much for this opportunity. I feel elated and honored to be invited in this great gathering and present this topic titled Opioid Withdrawal and Locus ceroleus neural pathway, the cardiovascular implication. Permit me to stand on the existing protocol. Due to the limited time, I will go on to commence this very presentation, which I believe is going to be an exploration for me to gain from you and share the little I had with the others. I'm very grateful. As introduced by the moderator, I'm by name Dr. Yusuf Alkali Ibrahim, specialized in neuropharmacology. So, these are my outlines, which I'm going to discuss on them. First, we have the introduction to the word neurocircuitry, opioid endogenous peptides, opioid addiction, opioid withdrawal, Locus, ceroleus, norepinephrine neural pathway, cardiac implication, treatment of opioid withdrawal, cardiac implications as well, and clinical suggestion and the very conclusion. Now, by way of introduction, as we spoke.
Sorry, sir. Sorry,
Yes,
sir. Dr. Yusuf.
Yes,
can
yes,
I
sir.
come in here?
Yes, sir.
Please, can you put the slide on
slideshow mode?
On presentation mode. Yes.
Okay.
Yes, better now.
It's better now.
Yes, it's better now. Thank you so much.
Okay, thank you. Thank you. So, by way of introduction, anything that has addiction potential, it is believed generally that it always interacts with reward system. Substances, xenobiotics, and other chemicals do interact with this new reward neurocircuitry, and that's what makes them to eventually have addiction potential. Now, it is important that I'm talking about opioid withdrawal. We have to discuss about the opioid addiction pathway. Now, addiction is a process or neural circuitry that involves specific neuronal regions in the central nervous system. These regions made up the reward pathway. The reward pathway is generally regulated by a non-neurotransmitter, which is called dopamine. But the reason it is released, the receptors it interacts in those special regions in the CNS makes it or make any substance that has tendency to modulate or increase the concentration of dopamine in these regions will likely have addiction potential. Dopamine neurotransmitter in the ventral tegmental area and nucleus accumbens, dopamine in the hippocampus, and dopamine in the prefrontal cortex. This very neural circuitry, that is the ventral tegmental area, nuclear accumbens, hippocampus, and prefrontal cortex, they made up the reward neural circuitry. They made up the reward neural circuitry. So any chemical agent capable of increasing the concentration of dopamine within these regions in the ventral tegmental area, hippocampus, and prefrontal cortex has great tendency to cause addiction. And the opioids that we are in question has this tendency. They do stimulate the receptors in the central nervous system, especially in the ventral tegmental area, in the hippocampus, specific subregions of the hippocampus. There are some opioid receptors that are expressed in those regions, especially the dentate gyres, as well as in the prefrontal cortex, where is the region that is responsible for decision making. It is also believed that this very region is subdivided into different divisions, including in prelimbic, and anterior cingulate cortex. This very anterior cingulate cortex also express mu, kappa, and delta receptors of opioid, and often stimulation, it has link, neural link that snaps with other nerves that releases dopamine, and they cause increase in dopamine concentration, and that's what eventually leads to addiction tendency of this very chemical agent. Now to the opioids. Opioids could be synthetics or the natural ones, derived from the plant Ophium fafi, that is perpheverin. Perpheverin is one of the alkaloids being extracted there. Then the main alkaloid that was derived from this plant is morphine. Morphine can be derived from the plant, and it has this addiction potential of a new set, and other derivatives could be derived from this morphine, such as demethylating of the morphine can yield codeine, and also the acetylation of this very morphine can also give us heroin. And all these are agents that are capable of stimulating new receptors and cause addiction. Endogenous peptides derived from enkephalin, prodanopins, and pro-opiomelanocholine. These are endogenous peptides that are produced by physiological system of the body, and they do interact with kappa, mu, and delta receptors. Upon stimulation of these receptors, they provide some level of tranquility, pain suppression, as well as stimulating certain cardiac receptors that express the mu kappa and delta receptors. Now, locus ceroleus is a region that is it's a region in the central nervous system that mediates release of norepinephrine. Now, upon usage of opioid has tendency to suppress the locus ceroleus norepinephrine pathway. Now, on continuous usage of this opioid, as a concentration or the usage is continuous, of a long usage, they tend to suppress the locus ceroleus norepinephrine system, in the sense that production of norepinephrine will be suppressed by utilization of the opioids. Anytime these opioids are withdrawn or abrupt withdrawal, definitely leads to a repercussion of withdrawal syndrome, that is reactivation of the locus ceroleus neurons that release excessive norepinephrine. And I have a lot to say regarding what norepinephrine does to alpha beta receptors in the cardiac muscles and in the peripheral blood vessels. And also the primary target for drug of abuse is this system, that is locus ceroleus norepinephrine system. Stimulants do engage this side as well as the opioids. The opioids suppress the pathway as I explained earlier. Now, activation of beta and alpha receptors in the myocardium will lead to tachycardia, positive chronotropic effect, increase in cardiac output, increase in force of contractility of the heart, and that could lead to increase in blood pressure. Again, hyperventilation withdrawal also referred to call respiratory alkalosis, in the sense that the excessive excretion of the carbon dioxide distorts the acid-base balance of the pH, respiratory pH. Now that could lead to tetany, which could eventually lead to cardiac arrest. Now, during withdrawal of opioids, there are conventional agents that are always employed. We all know them. These conventional agents include use of symptomatic approach, that is to treat the symptoms. Conventional agent most often for treatment of opioid withdrawal is use of the antagonist, that is use of opioid kappa, mu, and delta non-selective antagonists such as naltrexone and naloxone. But that was also associated with great cardiovascular implication because of an administration of this opioid receptor antagonist such as naloxone. They can precipitate hypertension because they have tendency to antagonize the opioid receptors. And the endogenous opioid in the system, upon stimulation of those receptors, they have tendency of lowering or controlling blood pressure. Now, when opioid antagonist is used at once, that suppression of blood pressure by endogenous opioid will be prevented. And eventually, that use of the antagonist like naloxone will precipitate hypertension and cause other cardiac symptoms. Now, another way that is used to treat opioid withdrawal is direct symptomatic treatment. Opioid withdrawal tends to manifest with increase in heart rate, sweating, frequent urination, pupillary muscles dilation, insomnia, inability to sleep. Now, direct use of agents to treat this, such as use of beta blocker, use of sleeping pills in order to get the sleep due to opioid withdrawal, that one too will not solve the problem because use of opioid and beta receptor antagonists directly could provoke another feedback mechanism that will increase production of norepinephrine that will eventually engage the beta-1 receptors in the heart and the other alpha receptors in the peripheral blood vessels. So that too has cardiac implication. Then the use of non-selective opioid receptor antagonists, it has been explained that it has these consequences of causing hypertension. Now, it is suggested best way to go is use of long-acting and slow onset of action opioid. That will be the best way to treat opioid withdrawal. Why will this be a preferential choice over the others? Because the activity of stimulation of the mu, kappa, and delta receptors of the opioid is required in order to maintain normal blood pressure. Now, we can't use the antagonists at once because of that repercussion effect of increase in BP, that consequences or implication, cardiovascular implication. Now, use of methadone will provide some stimulatory effect to those receptors, which will help to control the blood pressure and the other cardiovascular manifestations, unlike when naloxone or naltrexone is employed as direct antagonist. Agents with partial opioid receptor agonism, such as buprenorphine. Buprenorphine can also do well in treating opioid withdrawal symptoms because it has tendency to stimulate the mu kappa receptors and prevent and aids or support the control of blood pressure as done by stimulation of these very receptors by the endogenous agonist. Another option is use of alpha-2 receptor agonist. Alpha-2 receptor is well known to be an autoreceptor that controls negative feedback mechanism by reducing excessive release of norepinephrine. Upon stimulation of alpha-2 receptors, it will increase or facilitate the activation of negative feedback mechanism to the sense that excessive discharge of norepinephrine in the locus ceroleus region, it will be suppressed. As the concentration goes down, then symptoms of cardiovascular symptoms such as tachycardia, tachyarrhythmia, increase in blood pressure, increase in total peripheral resistance, all caused by the norepinephrine, will be suppressed because the production of the norepinephrine will be suppressed upon utilization of this alpha-2 receptor agonists. Examples of the agents that will be employed clinically includes the use of clonidine, the use of hexonidine. All of these agents can do well in controlling opioid withdrawal without much clinical cardiovascular consequences or implications. Now, the other way, or should be the last way that can be employed, is condition sensitization therapy. This is a neuropsychiatric therapy in the sense that patients that are addicted to these opioids can be treated without actually giving them the opioids. Where it goes in using this condition sensitization is that the very condition where the patient used to receive the drug, if they were receiving opioids on medical ground and they become addicted to it, and upon withdrawal, there will be these consequences of withdrawal syndrome that has great cardiovascular implication as previously explained. So condition sensitization is that the patient will be taken to the very ward or the very place where he receives those injections of opioid. Everything will be the same. The condition of the place, the odor of the environment, the presentation of the administrators, that is the physician or the pharmacist or any health caregiver that used to administer the injection, his presentation, everything will look the same. The condition will be the same. The environment will look the same. That will sensitize endogenous opioids of that individual to feel like, yes, when he's receiving a placebo treatment, he will not be told, but he might perceive, yes, he is actually receiving an intervention of opioid. And that psychological belief will help in him believing that he is receiving an opioid, and the symptoms of opioid withdrawal will be suppressed because as he is conditioned, his mu, kappa, and delta receptors endogenously will be sensitized. Being sensitized endogenously due to that this psychological belief that he is taking a drug will, as this condition sensitizes the receptor, the endogenous production of enkephalin, beta-dynorphin, and dynorphin is enough. The concentration, physiological concentration of this endogenous opioid is enough to activate those receptors and suppress all symptoms of opioid withdrawal. That is my conclusion and my clinical recommendation for ameliorating symptoms of opioid withdrawal. These are some of the references I use, and I thank you very much for your time.
Wow. Thank you so much for this wonderful presentation. This is our part presentation. Is so concise and straight to the point. I must thank you immensely for for the share of knowledge this night. We appreciate you, and we pray that God continue to strengthen you in knowledge, in health, and of course, in wealth.
Thank you. Thank you so much, sir.
Presenter has drawn our attention to so many salient points that we may not be looking at when we are confronted with management of an addict, especially that is going through opioid withdrawal syndrome. If you ask me, I would say that if we are not taking anything home this night, at least we should know that any individual that is addicted and is going through rehabilitation, and of course, we know that one of the major challenges in rehabilitation is withdrawal symptoms. And we should know that for those ones that on addiction of the stimulant, the opioid stimulant, we should be very careful in giving the antagonist. We all know that it is very common among drug users who are addicted to stimulants that the CVA parameters like the cardiac output, the total peripheral resistance, and of course the blood pressure, the pulse pressure are always on the high side. So we shouldn't just jump into choosing an antagonist because we know from our literatures that yes, it's an antagonist and we can just go ahead and use it to block the receptor, and of course resolve the symptoms of opioid withdrawal and not being put into consideration the cardiovascular implications of such an intervention. So I want to thank you again immensely, Dr. Yusuf Alkali, for this very wonderful presentation. A timely one for that matter, if you ask me, because drug abuse honestly is on the rise, and the regulatory agencies are making efforts to ensure that the public may live. In doing that, we are also being faced with challenges of withdrawal symptoms and all that. Most times in psychiatric clinics, we discover that the withdrawal syndrome symptoms are even more challenging than the substance that this individual has abused over time. So I think we have something to take home that will guide us in our decision making as regards opioid withdrawal symptom management. At this point, I want to give opportunity to our participants in the house that have questions, for us, or contribution. You can have any for us to rub mind and also make contribution. So please. Still looking at, I've not seen anybody that has raised or a hand up for question. Okay, yes, Dr. Mori.
Yes.
Good evening, you're welcome.
Yeah, good evening, everyone.
Good evening.
I'm quite impressed by tonight's presentation, though I will still give a vote of thanks at the end on behalf of our ELBO National Chairman, who is unavoidably absent. He's somewhere where there is no network. Okay, but I just have a few comments to make, and don't know whether it's a question or what. Tonight, we're able to hear a Latin word. The first time I saw that topic, I said, wow, what is this? I have quickly go through Google. I learned it's a Latin word, that Locus ceroleus. Yes, that is with night. Me, I work in ICU, and we always use opioids, analgesics like fentanyl, morphine. We use them a lot. And most of our patients are on those opioids and also on norepinephrine at the same time. So considering what your discussion we talked tonight, considering their pathways and how they interact, I don't know what you're going to say about it, because why we are using both at the same time is to reduce just to reduce pain, to sedate them, and also to improve their blood pressure by the use of norepinephrine. So please, what are you going to say about these two combinations based on your description tonight? Thank you.
Thank you, Dr. Morin, for that question. I think the presenter will do justice to that. So, Dr. Yusuf, over to you.
Okay. Thank you very much for this question, as asked by one of the participants. Yes, thank you, Doctor. So the interaction that is here is that use of the opioids, that is what you're doing is clinically okay. That is exactly what I'm highlighting here. That when there is use of opioids, that opioids has tendency to suppress the locus ceroleus norepinephrine pathway. And that pathway is responsible for production of norepinephrine. So when you are in continuous use of opioids, that pathway for production of norepinephrine will be suppressed. So it's good to administer exogenously another norepinephrine, because the endogenous one has been suppressed by the very opioids you are using. Now, what I discussed here, interaction, was when you abruptly withdraw the use of the norepinephrine. As you withdraw it, there will be a rebound effect to that pathway. That pathway will now be hyperactivated because of the absence of the opioid, which was previously being used, and abruptly it was withdrawn. Now that rebound effect will hyperactivate the locus ceroleus norepinephrine pathway, and that will lead to surge in norepinephrine release, and that can have cardiovascular implication, which can go beyond the physiological need. But the interaction of administering the opioid and norepinephrine is clinically in order, and it is in line with what I have explained, except when it is abruptly withdrawn. I hope I have responded to this.
Thank you so much.
Excellent.
For justice to that.
Yes. Thank you.
So, any other question or contribution? You can see that we actually have.
Yes, Dr. Alphonsus is raising his hand.
We had the case.
Dr. Alphonsus. Yes.
Okay. Dr. Alphonsus.
Yes, Peter.
Please, you have the floor.
Yeah, good evening, presenter.
Yes, good evening.
Yeah, wonderful presentation, I must say.
Thank you very much.
Yeah, mine is more of a question, and I think some minor contribution as well.
Okay, thank you. Okay.
Yeah, the third approach you gave seemed to be a very useful one. I do a lot of psychotherapy.
Good.
And I think those are the two kind of patients that I still see. You know, so I appreciate the relationship between the cardio and the psycho pathway, you know, when it comes to therapy.
Yes, sir.
Now I'm looking at, in Canada, I had visited Canada for some time. I was in Canada and I actually shadowed their pharmacy practice. I discovered that pharmacies were running methadone clinics.
Okay.
In community setting. Yes, there were places like that. You see so many of the clients, they sit down, they are waiting for the pharmacist. The pharmacist actually, takes care of all this withdrawal stuff you have talked about today. And they are passionately doing it, keeping records, and actually gaining experiences. I don't know, are you aware of anywhere in Nigeria, or as a person, are you involved in any level, whether minor, whether small, or, at a larger scale, of these practices? Because I know those things will actually create more room for pharmacist involvement. Like when you were speaking, you were saying that they will have to bring some healthcare persons. It could be a medical doctor, a nurse, or a pharmacist, so that the patient keeps thinking that he's been given the same product in the same environment, whereas it's more of a placebo approach. Exactly. So in my mind, I was saying this man is mentioning pharmacists. Are pharmacists really involved in this part of the world? So I don't know if you have any direct care experience somehow with it. I would like to know. But it was a wonderful presentation, and I think if there's a way you can amplify it, probably carry some other professionals along. Nigerian people will actually benefit. I'm sure there are a lot of patients that don't have this information, and some clinical settings that are not clinically oriented with respect to this, and we have a lot of issues going on now. Thank you.
Okay. Yes, thank you very much for this. I think, as you said, actually for now, we are only doing it in preclinical setting, and we have observed it is really working. And of course, even in clinical setting, unofficially, we used to do it to some patients. But like for the establishment of the centers for that, as you said, actually is something that is yet to be implemented. But we will work towards that and see that other professionals are also engaged, the psychotherapists and others. And of course, as you suggest, it will be a game-changing event, God's willing. So unofficially, we used to engage in it, but we are looking for a way of improving everything so that it will be officialized and often as a center, as you suggest, God's willing. Thank you very much.
Thank you so much. Dr. Peter, do you have more questions?
Yeah. He answered it quite well, but he didn't say much about the community engagement. When I used to be in Jos, more or less, I had met some psychiatrists. There's a hospital that's called Quintessential Hospital in Jos, somewhere around Goda Base, owned by Professor Audu and Professor Guleb. One of them, they are both past HOD of Psychiatry Department, University of Jos. So then I approached them that they should be referring patients to me. I went with Dr. Dangiwa. Dr. Dangiwa is one of the board of trustees of CPAN. So we met them. I had met them on my own before we met them together. And I discovered that one of their patients was a medical doctor. And the guy was on narcotics, was on opioids, and the guy was actually having the issues. So the consultant promised he was going to see a way so that we could work together, but we were always communicating. And because I was doing cognitive behavioral therapy at the time, and the man was not very knowledgeable with that, he was very much welcoming to whatever I suggested. So I'm looking at it that outside conventional, maybe government hospitals, if they are private settings where there are psychiatrists, you could move with your team. Maybe I don't know how many pharmacists are doing with you. If not, if you are not there, maybe nothing will happen. I'm looking at collaboration between you and some other pharmacists that have interest either in cardio or psycho, so that you work with all these healthcare professionals and win their trust. By the time you win their trust on personal levels, from their private practice, from other places, you will be shocked that they would actually embrace pharmacists at a higher rate than what you see in conventional settings. Conventionally in Nigeria, there is this phobia for pharmacists. When you go, people want to push you out, want to give you, want to push you without involving you as such.
Exactly.
Yes. When I was doing most of my PharmDs at MSc, I used to be invited by some nurses and some clinicians into hospitals. I had done psychotherapy on some patient. There was a patient that at a point was not taking medication and they had discharged him. So because of what I was doing then, one of the matrons said, no, there's somebody that could handle this case. So they called me and I gave the person some, session. By the time we finished, I went there in 2 days' time. It was the nurse that told me just at the counter that that patient had started resuming his medication, that I should come and enlighten them and teach them what we do. But at the point, I was not ready because I felt they were chancing pharmacists too much and they were not giving us our place. I didn't teach them anything. But the point I'm making is that there is a lot of ground if people like you are actually given a place, but then you may need to create that space. It's very important. Your presentation tonight is excellent, but I don't want it to be theoretical. A lot of pharmacists have stuff, but they don't go anywhere with it. So that angle I'm saying you should look at it, collaborative pathway, private clinics with psychiatrists and other people, and you could go into community and advocate for 1 or 2 places. Some of the medical doctors can refer patients to pharmacists in community if they know those people have those skills.
Yes. Yes. Thank you very much for this suggestion. It's well absorbed. Thank you very much.
Thank you so much, Dr. Peter. I think in summary, you are saying that Dr. Yusuf to see how he can, aside collaborating with other healthcare practitioners, but to also expand the family member of neuropharmacology, so that we have quite a number of pharmacists who are specialists in neuropharmacology and could spread across the length and breadth of the country, to provide the service. You can't give what you don't have.
Yes,
if not for this presentation today, most of us will not even think in that direction that there could be links between the neuropathy and the cardiopathy. But thank God, one of us has drawn attention to that, and I'm very sure when next we have a case before us, who, of course, handle it better. And my own colleague, Dr. Morin, who has always been in the intensive care unit and, has always seen contribution of medication being given, but really don't have very clear understanding of why that combination is, has also been able to see, in very clear terms, reasons for those combinations. And I think with this presentation, she could talk authoritatively in that direction, and of course, offer much more useful services than she used to in that regard. So please, the floor is still open for more questions and contributions.
Yes.
We are approaching 10 o'clock now. We have 10 minutes to 10. And so if there are no more questions, Dr. Morin is in the standby to give a closing remark on behalf of our National Chairman, Dr. Joseph Madi. After the closing remark, we shall go into another silent closing prayer, then we draw the curtain for today. But before Dr. Morin, please, I want to thank every one of us who has made out time to participate in today's presentation. I also want to thank the 2 colleagues that called in, made their contributions, and asked questions that has also made the presentation more beautiful and better understood. I want to thank you. I also want to thank the leadership of CPAN and the educational committee of CPAN, who has always worked round the clock to ensure that at least we have something to warm up our brain and put us in the same operational frequency with our colleagues at the other side of the divide. And so I want to continue to encourage us. Those of us that are able to make it today should also encourage those that are not able to join today's presentation. That anytime you see repeat of presentation, please time. It's just once in a week, and as you can see, we have not even spent up to an hour. We started actually at 10 minutes past 9, and this is 9:53. So we have not actually spent an hour. If time is managed properly, I think within a short time, we'll benefit so much, and we'll go back to sleep. And so once we can continue in this trend, put this together over a period of 12 months, you can imagine the wealth of knowledge that you would achieve without paying a dime, except data that you're going to use. So at this point, I want to appreciate everyone, of course, that made it today to be part of this presentation. Dr. Maureen, I see that you're on the standby. Okay. Can you give us a few remarks on behalf of Dr. Joseph Mad?
Okay. Good evening, everyone, once again. On behalf of our dear chairman, Dr. Joseph Madu, who is unavoidably absent, I want to congratulate all of us that are here present to listen to this wonderful presentation tonight. Also want to congratulate clinical cardiology pharmacy group of our specialty group for organizing this wonderful presentation despite the short notice. I want to especially thank their two desk officers, Dr. Nuruddin and Dr. Maureen. Just within a week, they were able to put up this, especially our dear presenter. Thank you so much. And also the moderator. So we are grateful. At least we started again after the National PSN conference, though we will soon go back for Christmas break and we'll kick it off again early next year. So thank you so much for making it possible tonight. We've learned a lot. We now know how to manage our patients that are addicted with opioids and the side effects that may arise, that's the cardiovascular side effects. And our Latin word tonight, LC, we'll never forget. Thank you so much. Tell your next. Thank you.
Thank you, Dr. Maureen. So at this point, I want to ask us to go into prayer mode again, just for 30 seconds. Shall we pray?
Sure.
Amen.
Amen.
So do all have a wonderful night rest and weekend as we draw the curtain.
Okay, thank you.
Thank you, the presenter. We are grateful.
Thank you, sir. Thank you.
Good night, everyone.